Okay, good morning, guys. We are recording. Today is September 8th, 2022. We have Dr. Yasmin Kim speaking to us today, our PACU resident, about stroke in the PACU. So thank you so much for your time.
Yeah, thank you for having me. Again, if y'all are online on Zoom, but in the building, there are donuts here if you want to grab one. But we will go ahead and get started. Again, I'm Yasmin. I'm one of the CA1 anesthesia residents, and I'm going to be talking about stroke in the PACU, or more specifically in the perioperative period. So just a few objectives for this talk. I think it's always really helpful, at least to me, to kind of do some definitions and terminology. So we'll kind of talk about the different types of strokes. We'll talk about surgery guidelines on when someone should, like, in theory, have surgery after they've had a stroke, and then kind of talk about patient surgical risk factors in addition to treatment of stroke, and kind of how I think it's most helpful to approach, oh, you think someone has a stroke in the PACU, what do you do? All right, so some terminology first. I think the word stroke, is always very confusing because there's different types of strokes. So the way that I think is most helpful to me is to think about it as an acute stroke, a transient ischemic attack or a TIA, and then a covert stroke. And for our purposes in the PACU, really an acute stroke and a TIA are kind of the same, the same thing to us, because the definition of an acute stroke is really a focal neurologic deficit that persists beyond 24 hours, whereas a TIA is less than 24 hours. Obviously, by the time these patients are presenting in the PACU, we don't know how long that will last. And then covert stroke is another kind of category of stroke that I think is really interesting, and that we don't really have a lot of data on, but it's basically an asymptomatic stroke. So someone had a stroke a while back and it's discovered on, let's say, a routine MRI or maybe a CT scan. And where this is kind of interesting in terms of more research is that it's actually been, there's evidence to suggest that these people still have like a significant degree of cognitive decline or even, decrease in function that we really don't have well studied. All right, but going to more definitions. So perioperative stroke, when I say that, I basically mean a stroke that's happened in the operating room or any within 30 days after surgery. So all of that is kind of considered the perioperative period. But 50% of strokes occur within 24 hours postoperatively, either intraoperatively or postoperatively. And actually 75% of them occur within 72 hours. So most of the time, we can catch probably a good bit of them in the PACU, or certainly once these people are hospitalized if they aren't going home. All right. So I think it's also helpful to go over, surgery after stroke, kind of what the risk factors are, because I think we see a lot of these patients who come in who say, oh yeah, I've had a stroke. It was years ago, or maybe it was like 2 months ago, which are very different in terms of, their morbidity and mortality if they undergo surgery. So the guidelines that we have this is all like consensus guidelines from the AHA, ASA, as well as the ANA, that really elective surgery should be delayed at least 6 months, but preferably 9 months after someone has had a stroke. Where it gets a little more dicey is the time-sensitive surgeries where, let's say someone has cancer they need an operation for, at that point, it's a matter of weighing the risks and benefits. But really important to note that if someone has, a surgery within 3 months after a stroke, they do have a 67-fold higher increase of having another stroke compared to the average population. And actually mortality in those patients is, close to 20 to 25% if they have a stroke. So they're pretty devastating strokes. Emergent surgeries, not really much that you can do about that. If it's emergent, you have to do it. It doesn't matter when they had their stroke. But again, where I think all this is important is for some reason, if you're having a patient coming into the PACU, let's say they've had a stroke within 3 months or within 6 months, important to note that they are at an increased risk of stroke. So when you see, I guess I always think about having a heightened awareness. Let's say if that person has some kind of funny issues coming out of anesthesia, or you feel like there's something wrong with them cognitively once they wake up in the PACU. So no, for that, it's both, which is a good question, which we're going to talk about a little bit more here. But yeah, basically the guideline is 6 to 9 for thrombotic or thromboembolic or hemorrhagic. And that segues very nicely into the different types of strokes. I know you all probably already know this, but I always just think of it as like block versus bleed. Those are the two types of, acute strokes you can really have. So you can have an ischemic stroke, which again is either thromboembolic in nature, or the hemorrhagic stroke, which is, our subarachnoids or intracerebral hemorrhages. I would say in the PACU, though, the data that we have suggests that ischemic strokes or thromboembolic strokes make up the majority of the strokes that we see here. I have a suspicion that's really due to the fact that a lot of people, they're less likely to bleed. They're not on anticoagulation generally, a lot of people, once they're having surgery. So less likely to bleed, but certainly more likely to clot. Anyone have any questions about that? Okay. Risk factors for ischemic stroke. So now I'm going to kind of focus mostly on ischemic stroke at this point. Patient risk factors, again, the big thing is really age and a history of prior stroke. If they have any type of renal dysfunction, particularly dialysis patients, and anything wrong with their heart. So whether that's congestive heart failure, AFib, or a mechanical valve. The mechanical valve usually has to do with the fact that these people are chronically, generally anticoagulated and may have to hold that prior to surgery. So they're just at more risk of throwing a clot. I think it's also important to talk about procedural factors. Again, we obviously don't see much like cardiac or necessarily carotid, necessarily not cardiac surgery coming necessarily through this PACU. But cardiac surgery and carotid surgery have really, really high rates of stroke, upwards of up to 15% in some studies. So in those patients, it's, again, if you're ever taking care of those patients, have like a higher threshold if you feel like something is wrong, to let someone know. And then big abdominal surgeries. Those are the other things where there's a higher increased rate of stroke. So things like XLAPS, anything to do with the liver transplants, kidney transplants, that type of thing. And also amputations. I think a lot of this has to do with the fact with the amputations, though. These are usually people who are kind of vasculopaths, so they might have pre-existing kidney disease, or again, just more prone to clotting, but also important to know. Okay, signs and symptoms. I'm not going to spend too much time talking about these because I think we all kind of know them, but the big thing is, really cranial nerve deficits and motor deficits. When someone comes out of the PACU, those are like big warning signs where like you should let someone know right away, high threshold to think about a stroke. I think the harder thing is when you have maybe sensory deficits, or someone who's just like newly agitated, confused, or some type of change in mentation. Just because we give so many things, pain medicine, obviously the anesthesia things that we give in the operating room, that make it really difficult to kind of tell, oh, is this just, the anesthesia and the pain meds, or is this actually something else going on? But yeah, any type of cranial nerve deficit, motor deficit, that really gets us concerned. Lastly, just kind of a switch to treatment. Really two treatments for ischemic stroke. You can have thrombolytic treatment versus endovascular. Thrombolytic is, for us, we give TPA. Again, our window here is within 4.5 hours of last known normal. However, there are many contraindications to that. And obviously, as you might imagine, in a surgical patient where sometimes their last known normal might be before their surgery, which maybe that was like 6 hours ago. So they're out of the window, or, there's a concern for bleeding. So this is really, the decision to give TPA is certainly like a discussion between the surgical team, the anesthesia team, and kind of figuring out if that's something that's really best for that patient. Endovascular repair, basically mechanical thrombectomy. This can be done within 24 hours of someone's last known normal. And it's actually really nice because it doesn't require any anticoagulation. So particularly like our surgical colleagues, I think, are a little less, concerned about that mode, just given the fact that there's potentially a decreased risk of bleeding. Although actually in the studies that we do have on patients who've gotten TPA, their risk of bleeding has actually been shown to be that significant, but topic for a later day. Any questions about treatment for ischemic stroke or any of the other signs, symptoms, anything like that? I'm just gonna, this slide is kind of a lot, but kind of quickly go over, what a code stroke, well, we all know what a code stroke is, but kind of the details of a code stroke and in theory, like how things should go. I'm gonna start first on the kind of talking about the timing. So really when there's a discovery of a symptom to a stroke alert, so actually a code stroke being called, In theory, it should be 5 minutes. So like when you all notice something different on your exams, because you all are going to be certainly before I know in PACU, when something is wrong, really within 5 minutes is when we should be activating a code stroke if we think this is a stroke. And then neurology should be talking to us within 10 minutes of that. And then at that point, within 25 minutes, if a code stroke is activated, yes, okay, this seems consistent with a stroke. At that point, it's really about getting to CT to do some further imaging. And the patient needs to be down in CT within 25 minutes. That's kind of the guideline for that. And does anyone know why we do a non-contrasted CT? This used to always really confuse me. Yeah, exactly. Yes. So that's what I think is really important to note, is that really like a stroke diagnosis is a clinical diagnosis. The head CT that, the reason we're getting a non-contrasted head CT is really just to see, is this patient bleeding? Because if it is a hemorrhagic stroke, then they are not a candidate for TPA, and we're not going to even go down that route. But just because that, that head CT is negative does not mean they're not having a stroke. And often, honestly, at this point, almost everyone will also get, CT angiography of their blood vessels as well to kind of further identify, is there, something going on and they might be a candidate for thrombectomy. So that's kind of what this middle portion here is talking about. But yeah, so the head CT, which I think is funny because I think in the ICU, we get this a lot. We're like, oh, let's just get a head CT. Let's see if they're like having a stroke. Well, that's not going to, the stroke, if you think it's a stroke, you need something more than a head CT. But I think we often get it just to kind of make ourselves feel better that there's not a big brain bleed there. And then lastly, these other things here, we've kind of already talked about. This isn't really as relevant to us. This is more for our neurology colleagues once they get in, but basically the CT or MRI needs to be read within 45 minutes once it's been done and communicated to the teams. And then, obviously this last box talks about, within 60 minutes is when, TPA should be given if they're a candidate, or within 75 minutes if they're a candidate for mechanical embolectomy. Technically for us here, our protocol is within 25 minutes is when all of the teams, anesthesia, surgical, the patient's family, whoever it may be, need to have a decision on whether or not TPA should be given. And obviously neurology, they're going to be helping out with that, of course. Any questions on the timing? Really like 5 minutes and 25 minutes, I think, are the two most important things to think about, because neurology is generally, like, obviously they're pretty good if there's a code stroke called about coming right away and chatting with us. This first box here is where I think it's kind of, important, particularly from your all's perspective, to kind of think about, what are the next steps or the things that, we need to worry about. And a lot of it is a lot of things that you like already do, right? Like checking a point of care glucose, getting vitals, getting a second IV, particularly if we think they're going to get a CTA. So second IV to pull labs off of, or if obviously they have an ART line, you can pull off of that. Also confirming last known normal. This is something that we'll all kind of do at the same time, but often there's a million things going on, as you all know. So if often you all spend the most time with patients, when was their last known normal? That's really helpful information to share with the teams, particularly neurology. Okay, that's all I have on that. This is a picture from when I was in Iceland, when this was a couple years ago now, there was a actively erupting volcano. And this is often how I feel when a code stroke is sometimes called, but not even when a code stroke is called, but just like, you're like, okay, I just got to deal with this. So there's everything exploding in the background. And yeah, so anyway, that was a nice trip. It is now erupting again. It stopped for a while. So if any of you are going to Iceland anytime soon, we recommend that. It does pelt a lot of rocks at you. So try and stay away from that.
I wondered if you get any residue. Or...
Yeah, literally volcanic rock, because the lava, yeah, it was not good. Probably not safe. I probably shouldn't share this, actually. This is not advice to, but yeah, and I think this kind of ties in nicely to the next thing that I want to talk about, is really just quickly other causes of stroke. Because I think, for me at least, I don't know if you all feel this way, because obviously, it can be a little different, but for me, the big thing is, when do we call a code stroke? Like, are there other things that could be causing, issues with this patient that, need to be addressed first. So kind of this in-between zone. So I think the easiest way to kind of think about this is, let's say you don't have a patient with cranial nerve deficits or motor deficits, but just someone who's confused or they're not normally like this. I like to think about like 3 categories that could be contributing to why they're kind of confused or altered in some way, and try and address those. And really the last one that we address here is neurologic. So for example, I think pharmacologic is often a really common cause of, of altered mental status and the things that we do here. So things like opioid medication, whether that's in the OR or pain medicine that they've gotten here, things like benzodiazepines, depending on if that was given in the OR. Also, from the anesthesia itself. So the anesthetic agents, like, the anesthesia gas and the propofol we give can really create a brain fog for a lot of people. And also paralytics. So the reason, almost everyone here I feel like gets reversed with Sugamidex, but obviously important to remember that Sugamidex wears off. So if all of a sudden someone's starting to be weak, it could also be that maybe there's residual muscle paralysis because the Sugamidex that we've given to wake them up and reverse them is now wearing off. And then finally, metabolic, so things like hyperglycemia, hypernatremia, and temperature issues, so hypo or hyperthermia. And that's why, if you'll see here, kind of just going back, like in this initial section here, that's why they're always like, okay, yeah, get a blood, a point of care glucose. Well, let's get some basic lab values. It's really to kind of try and address some of these other causes that might be causing someone to be altered. And then finally, neurologic. So, because someone's altered doesn't necessarily mean they're having a stroke or an acute stroke. It could be. More often, if it's someone who's had a stroke in the past and they're having, deficits now, it could just be what's called like a recrudescence of an old stroke. This is never a diagnosis like I would make or we would make and just be like, oh, this person had a stroke. This is probably just from their old stroke. We would always talk to neurology, and they would really make this diagnosis. But, some patients, if they've had an old stroke, even if they don't have existing deficits now, there's a lot of stress factors having surgery, particularly hypotension that sometimes occurs in the operating room, that could cause kind of their old stroke symptoms to reappear. But it's not a new stroke, it's technically old. But again, we never make that diagnosis. And then finally, seizure, also important to think about, and then delirium, of course. This chart here is really just another way of kind of thinking about these things on the left, because I do tend to put like, altered mental status in with delayed emergence. That's what I think about it. So what are the things that cause delayed emergence? And I just kind of run through this checklist. So first, obviously making sure vitals look good, everything's okay. If that doesn't solve our issue, then I think about drugs. So do we need to reverse anything? Do we need to give Narcan? Do we need to give Sugamidex again if they're having residual muscle paralysis? And then finally, also like the lab work. So blood glucose, electrolytes, those types of things. Any questions about any of that? Okay. This is just another chart that you, if you want for your reference to look at, but okay. Again, I put this in here just to like, as an aside, again, if you don't know if this is really a stroke or not. I think we had this the other day with, I don't think Sarah's here, but we had a patient who like just had a pupil that was more sluggish than the others. Like it wasn't more sluggish. They were equally reactive, but one was bigger than the other. And we're like, well, is that new? Has it always been that way? Like, what do you do? That's technically, if that's new, I would be concerned. But, in the reality, that was, likely not a stroke. And after doing some digging in the patient's chart, he had, previous eye surgeries, all this other thing, but you don't know that in the time, like the patient's too asleep to tell you anything about it. So I think, and please feel free to add into this list, but something that's just like kind of helpful to think about if we're potentially going to call a code stroke, which is again, get help, neurochecks and vitals every 15 minutes, last known normal, do they have existing deficits, appropriate access, and then all the labs that we've talked about. And I added the transport monitor more for myself because that is something I always forget when I'm transporting patients to the ICU out of the OR. So, or bringing them back, I should say. All right. That's all I got. That's a lot of info. this is just my dog. This is Spot. She's about 6 years old. I just threw her in there just for fun. So what questions do you have? Comments? Has this ever happened to you? This in-between zone and it turned into actually being a stroke? That's always what I worry about.
I think the biggest thing for like our staff is like, you know, deciphering like go notify anesthesia, whatever, like that's like the, you know, first hurdle. And then because we're an accredited stroke center, there's so many things that have to line up with our documentation, nursing wise and physician wise, that it becomes so stressful. And like we're so worried about ticking all the boxes of documenting and then forget to even like do a thorough like, you know, assessment on that patient.
Yeah.
Like, everything does happen. I love your referral of like the book, you know, it's like
all at once, all at once.
Yeah.
Yeah, no. And I think when it comes, like, at least for me, no neurodeficit is too silly to mention. We would always rather know, even though I'm sure there will always be people who give you looks and maybe roll their eyes later, which is not nice, but would always rather know. Even Sarah, after this happened, I mean, this was literally what, yesterday, 2 days ago, I was like, thank you for telling me. I would rather know this. And we figure out that it's actually nothing new than, you know, have this be an issue later on and like you be worrying about it or something, you know, so.
For 26, break, and the patient had just come in, and the report was kind of spotty, but definitely the neurological system was. So should I do that? Should I go?
Yeah.
I really didn't think about it, and they called the and they went downstairs and they had to give a TIA. So
Yeah.
they had a big deficit. The smile was like overlapped by one eye was kind of, nobody could really decide whether it was like that before surgery or after surgery. Kind of interesting.
Yeah.
But
And
it made me a little more happy coming back at that kind of a little bit deal.
yeah, and especially too, I mean, even if, like you said, if it's a TIA, I mean, that's still a form of a stroke. What, like, but a better way.
Charting should not be the focal point. Patient should be the focal point. Doesn't happen.
Yeah.
I like what you said at the beginning too about how like every patient going under surgery poses them at higher risk. You know, so we have to think about that with every single patient. Just because they're going under anesthesia, gives them another like, you know, yeah, like another layer of like their risk factors. So it's smart to like get somebody involved just sooner or later. And,
Yeah.
Not second guess it.
Yeah.
There was one comment, I don't know,
Oh, yeah. Yeah, I've had someone with a minor droop that ended up having a new stroke. Yeah, exactly. And sometimes too, it's one of those things where, you know, we catch it early. So a minor droop can turn to something much more serious later down the line. And, you know, in the studies that we do have, you know, it's hard, right? Because again, sometimes these are often discovered when a patient goes back to the floor. They're more awake, their stroke has progressed. So there's obviously only so much we can do here. But I think, you know, just being aware, like having a low threshold to notify someone of new neurologic deficits. I mean, that's why the neurologists are here, right? I mean, we've had to do that. And no, I mean, I do really like, that's tough. All the charting is tough to like do all of this. All I will say is we always appreciate your work with the patient, and that like at the end of the day. Yeah.
I never really got it in the one. I mean,
Yeah. Any other comments, thoughts? Anything else that would be helpful to know? Okay. Well, thank you all for
Have some
listening.
sugar.
Yeah, have some sugar, please.
Thank you. I'm gonna grab.
Oh, hold on.
Oh, another.
Um,
pictures.
Yes, shouldn't there be a focus on their neurologic baseline in their H&P? Yes, absolutely. This is actually something that I really like to do now, Mike, is just making sure that patients all have equal strength in their arms and legs, like at least as an anesthesia provider, right? Just making sure that they can move everything, or at least documenting, is there one side that's more weak than the other? So yes, I definitely agree with that. I think that's definitely an area that we need to potentially improve on. And actually with that example that I gave with this, the eye issue with the patient, in their pre-op, assessment, it was documented that their pupils were, equal and reactive and all this. So that also created some issues for us of like, oh, well, is this true? Is it not? So it's hard because I don't want to create more charting, obviously, either.
Right.
So
And
yeah,
the charting it's gonna be there regardless.
it's gonna be, yeah.
And
So that's
fact-
tough.
Yeah, but I mean, I think it's awesome that we are an accredited stroke center.
Yeah.
We can treat these people acutely and we have success in it.
Yeah,
So,
absolutely.
yeah.
Awesome. Well, thank you all so much for listening.
Thanks, everybody on Zoom.